There we go. Think everyone's with us now. It's 2 minutes past 8, so let's go. So good evening, everybody. For those of you that don't know, probably most of you, I'm Steve Sheldon from Celtic SMR Healthcare, and delighted to be here this evening with our latest webinar on the laser this evening. Yeah, thank you for joining us. Hopefully you can see on the screen, you can see our website there. That's just a quick bit about us. This is us, for those of you who don't know. These are the products that we do here in the healthcare side of things. The MLS laser, which you won't be surprised we do, because hopefully is why you're here this evening, to hear a bit more about that on the plantar fasciitis. We do diagnostic ultrasound and we do magnetotherapy. As I say, we've done a number of these. This last year, we've done a number of webinars. I'm really proud of Celtic SMR Healthcare and what we've delivered. All 3 webinars on the scanning and on the laser in particular. And you can catch up here. If you just go here on our website, you can see the screen. Can you, Kirsten, can you give me the thumbs up? Yeah, you go here, Healthcare CPD, you can catch up on a whole load of webinars that you've missed. So if you haven't been with us before, where have you been? We've done so much. So here you go, just scroll down here and there's all the scanning webinars. 2 guys in particular do 2 guys, 99% do webinars, Abid and Adrian. You're going to hear from Abid shortly. He's got our laser, and you're going to hear a case study from Abid. But these guys have delivered some amazing webinars on the scanning side of things. Look at all that content there. Go in and have a look. It really is well worth it. There they are, 2 handsome, very clever chaps. I call them the Djokovic and Federer of the ultrasound world. I mean, if you can imagine those 2 guys playing doubles together, that's what you get when these 2 present for us, typically on a Wednesday evening. They're great. Really are grateful to them. Then we go on to laser. If you keep scrolling down, we got a whole load of a library of different webinars that we've done before. You'll notice Kirsten's in there. We're going to see Kirsten again later tonight in a short while. So that's a little bit about us. So thank you for joining us for this evening. So grateful too. Let me tell you who you're going to listen to tonight. We're going to do something slightly different tonight. We're getting 4 case studies from a couple of case studies and some good conversations from a couple of our ASA laser superstars. We have, in no particular order, just from the screen that I'm looking at, we have Kirsten. Kirsten's joining us. She's delivered and I've lost count how many presentations she's done for us now. And has been an amazing support for us. Let me let 1 or 2 people in. I am a bloke, you will notice. I can't do 2 things at once. So let me just let 1 or 2 more people in. 2 people just joining us. Let's let them in before we get into the main nitty gritty. Yeah, so Kirsten, what was I saying? Kirsten's been an amazing support to us here at Celtic SMR Healthcare. She delivers some great presentations for us. She's one of our key demonstrators. She does a great job on that and some training for us too. So for our users, some follow-up training, and for people that are considering the laser and during the trial, she gives them support there too. So Kirsten's an absolute superstar for us. We're really, really grateful and looking forward to hearing from Kirsten again in a short while. Then we go to Gwyn. Gwyn is another ASA laser superstar, the foot monkey, as he's otherwise called. Gwyn has got a real thorough understanding of the laser, the mechanics of the laser. So it's always great for him to join us. He's becoming a bit of a go-to guy for our ASA laser superstars out there on our laser forum. So looking forward to hearing from Gwyn in a short while too. Then we go on to Abid. Sorry, Abid. I already mentioned Abid. Abid does the scanning webinars for us. So a real good friend of us here at Celtic SMR Healthcare. But he also has a laser, our class 4 laser, and our magnetotherapy, and is getting some great results and is always happy to come on and talk to us, even at short notice. Apologies for that, Abid. Even at short notice to come on and talk about the laser and his experiences. So look forward to hearing from Abid. And then last but not least, we've got Adam Smith, been an amazing support again to me and all of us here at Celtic SMR, particularly in the podiatry arena, spreading the good word of how great the laser is and the great results that the guys are getting. Okay, so I think that's enough of me, don't you? I think I'm probably going to get the thumbs up on all that. Slightly disappointed that some of our Azer Laser superstars out there are not styling out the goggles, the glasses. I was hoping for a selfie tonight, but nevertheless, we won't let that let us down. We won't let that stop us. Anyway, one or two people still joining us, so let them in. So what did we say we were going to do first? We were going to go to, let me remind myself, we're going to go to Abid. So good evening, Abid.
Good evening, Steve. Thanks for the introduction. Sal, good evening, everybody. Good to see you all. Some new faces there that I've never seen before, and some faces that I recognise and are familiar. So
yeah,
one or two
of our scanning friends have joined us, which is great.
Oh yeah, they've got nothing better to do. That's why.
And now I know that you never have anything else to do on a Wednesday other than talk on Zoom. Anyway, over to you, Abid.
Thank you. So to kick off for this evening, I'm not the most academic type. I'm a clinician. I'm surrounded by other people that are way more clever than me in the world of lasers. So any more specific questions, maybe save them for the other chaps. My story really is just to go back to the beginning, how it all started, and to give you one case study. There's always that one patient that you've just got to start with. You're going to have a bit of confidence and kind of know what you're on about, and just be willing to dip your toe in the water. Forgive the pun. So I came across laser by accident, really, and it all goes back to the beginning of the pandemic. When it all kicked off and started, there was a whole hubbub around steroid injections, right? So most of my work is injection based one way or another, whether it's NHS or private. I tend to get the really horrible, chronic-y, long-term type of ones. So steroid injections became an issue because of the risk to the immune system, blah, 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 whatever your thoughts are on it. And at the trust that I worked at, there was pretty much a ban. A complete ban on steroid injections, and of course I'm going through that and looking at the evidence and research with the orthopedic chaps and whatnot. Of course, took what I found there across to private practice, and so I decided for the first probably 6 months of it not to do any steroid injections if I could at all help it. But then the question, of course, was, well, what can I do, other than the usual orthotics and stuff like that. So that's when I knew Steve and the guys had laser. And I'd been playing around looking at shockwave and laser and looking at the evidence and research behind it for probably a year before that, trying to figure out what would be the next gadget to buy. I'd had experience with shockwave in that I'd referred a lot of patients for it, but I wasn't really getting very good feedback from it, and a lot of patients were having multiple treatments and sessions, and it just didn't quite do what I was expecting it to do. I didn't have my own version, so I can't comment directly. It was just secondhand information from patients who tried it. So essentially, with the laser, it's now 12. How long have I had it, Steve? About 15 months, I think, isn't it? 12 months, 15 months, maybe. So I've done a lot of work with it in that time, and I have to be honest and tell you straight, it has absolutely, completely changed my practice. I do a lot less injections as a result of it. So the first case that I had was a lady aged around 56 who's a florist, so sort of slight to medium build, and she had one of those absolutely rip-roaring inflamed heels, the type that you see where there's just fullness and thickening of the whole heel. It just feels very turgid. It's exquisitely tender and painful to palpate it. Luckily, I have ultrasound in the clinic, so I generally scan a lot of them, and we found that there was some subcutaneous thickening there, and the plantar fascia itself was way in excess of 8-point-something millimeters, and there was severe vascularity all over it, and this was really a huge problem for her, but she'd managed with it for several months anyway, so there's no immediate urgency. But typically on any other given day, I would have gone straight for a steroid injection, because I know for me it will be a one-off. It'll likely improve the symptoms up to 80% within a week or two, and despite what you think about it, that's kind of what we do. So with this lady, I'd only just received the laser machine, and I hadn't yet had time to go through the instructions or the manuals or anything like that. I just kind of knew there's presets on it. I think I can figure it out as I go along, as you kind of have to do in private clinic a lot of the time. So flick the switch and set it up on the plantar fascia setting. I used the handheld probe. So the only thing that I wanted to make sure of is whatever I was going to do, and I signed her up for a course of 4 to 6 treatments. I said, look, I really don't know, but if you're happy to go along with me, there's very little else we can do at the minute. And worst case scenario, if you're really unhappy at the end of it all, I'll give you your money back, because I need to just test it and see. So we had a bit of an agreement, understanding, consented for the process, and I was really, really dubious. I didn't think it was going to even touch the sides whatsoever with this huge heel. So I had backup plans. I was going to put her into a walker boot and do all sorts of other stuff to offload it. But I thought, okay, let's do the basics. So I gave her the simple insole. She wasn't particularly overpronated. The biomechanics was fairly unremarkable, other than this rip-roaring heel. So we started with the plantar fascia setting, and I did 2 cycles on that setting. I can't remember all the details of it. I haven't got it in front of me, I'm afraid. Perhaps some of the other guys can fill you in on the wavelengths and whatnot of the plantar fascia setting. And the way I used it was, I didn't use the Charlie head. I didn't really hadn't really figured out how to use the Charlie head well. All I knew was I wanted to have maximum contact with the patient around that heel. So bearing in mind, it's incredibly sensitive, so I could go very light. But essentially, if that's the ball of your heel here, and then we're going into the arch. So I placed the probe pretty centrally to start with. And so I started very centrally, allowed several seconds, maybe 10, 15 seconds in that position. And then I just created a small winding circle. And then I moved over to the medial calcaneal tubercle, so slightly more medial. And I carried on this process for a couple of minutes. When I felt I'd done as much as I needed to there, probably 2-3 minutes later, I started to move up just anterior, just off the edge of the calcaneum, and coming up to sort of the mid portion of the plantar fascia, and just stroking it along. So I kind of go from the enthesitis right at the back of the calc, and then just stroking along. I applied a little bit of oil, and I put a cling film wrap onto the head of it. And actually, I like CBD oil. I use CBD oil to help with whatever way that does. And we just use that very gentle touch, so that was the protocol. So first treatment, we did it. Felt kind of good at the end of it. I thought, yeah, I think I've got the hang of this. Got her back. The protocol was 2 treatments in the first week, 2 treatments in the second week, and the idea was we'd just evaluate and see how we went along. So after the first treatment, she came back, and pretty much nothing happened. She hadn't noticed any improvement. She hadn't noticed any difference whatsoever. The heel looked to me pretty much the same on ultrasound. The difference was I was measuring as we went along with ultrasound. And there was just no difference whatsoever. So I thought, okay, I'm going to just stick with it to start with. So we did it again. And I think I did two cycles the first treatment, but I think on the second time I changed it. I just upped it a little bit and did a 3rd cycle. I think, correct me if I'm wrong, Steve, is the cycle about 5 minutes for plantar fascia off the top of my head? It's either 5 or 8 minutes, I think, isn't it?
7.
7, okay, right in the middle. I was close. Yeah, so did 3 cycles. So whether or not I should have used the Charlie head or whatever, I'm interested to everybody else's story this evening anyway. But that's what I did. So after the second treatment, there was an improvement. There was suddenly, she was feeling a bit of a difference. Looked at it on ultrasound, didn't look much different on the plantar fascia itself, but physically I could feel and see that the heel had eased. It wasn't so turgid. It wasn't so sort of full feeling, and it was a lot less sensitive than it was initially, where I could really barely put a finger touch on her without her, kind of jumping through the ceiling. So second treatment worked quite well, and then it just progressed from there. 3rd treatment, she came back the following week. It was further improvement, and the 4th improvement, and I was scanning all along the way. And after the 3rd treatment, that's when we started to see the changes on ultrasound on the plantar fascia. It started to reduce in thickness. So altogether, it's quite a long story short. We went up to do a course of 6 treatments, and the patient was just chuffed a bit so the whole way through. She really felt the benefit of it immediately after the treatment, and then for several days afterwards. And then by the time symptoms were just starting to recur, she was back over again. So with the total of 6 treatments, bearing in mind the plantar fascia was 8.3 at the initial stage, with a little bit of vascularity in there. By the time we'd done the 6th session, she was down to measuring 5.3 millimeters on the ultrasound of the plantar fascia. So there was a clear difference after 6 treatments. She was happy with it. Although the plantar fascia hadn't completely reduced, I would have liked it to have been about 5 mil, maybe 4 or under. But she was more than happy with the improvement. She was walking around. She was doing what she needed to do. She was working and able to spend as long as she needed to on her feet. So sonographically, it looked probably about, I don't know what, 60%, 40-50% better than it was when we started. But the clinical symptoms had improved probably at least 80%, if not a bit more. Such to the extent that we left her on a SOS, and then we telephone reviewed her 2 weeks after as well, after the 6th treatment, and she was still chuffed to bits and she was happy with it. So I thought to myself, look, well, plantar fascia is a really tough thing to treat, I think, with all sorts of treatments conservatively. It's, got to get through that deep fat pad in the heel, and you've got to get pretty deep in there, close to the bone to really get to it. So really was dubious about it. But now having done that one, and subsequently now I think I've done at least 10 or 15 plantar fascias where, more than likely would have had an injection otherwise. They've all done really well. I can't think of one that's not improved, but I have had a few cases who've complained a few days afterwards that they've had an increase in symptoms, an increase in pain. So I've had a few cases like that where they've reported symptoms afterwards, but generally speaking, on the whole, 80-90% of stuff, peroneal tendons, Achilles tendon, this, that, and the other, we had it as part and parcel of the treatment, or that is the treatment full stop. And touch wood, thus far, I can't really say there's any cases that haven't got better other than the couple that I mentioned. So good stuff.
Thank you, Abid. Really appreciate that. And there you go. We tell the story, and we tell people warts and all. We're not. This is not. It is how it is. So that's great. I suppose. I know you've got a dash, so we're going to keep the Q&A till the end. But I think the key thing there is on sonography, where you did the scanning and you got it down from, I think you said I think I wrote down 8.3 in my scruffy notes to 5.3 mil. The difference there is where you first saw the patient, and if you'd have touched her, she hit the roof, you were scraping off the ceiling. You then could obviously then introduce the mobilization, and that's a really key message about this laser, isn't it? That you've got to get the patient to a point where you can get them to do the mobilization you want them to do. I think that would be the take-home point there. Would you agree? Yeah,
and with that handheld probe, you can get into all the little nooks and crannies and really get the power where you need it most. So very, very versatile bit of kit, and like I said, I've done most MSK stuff with it. We've done OA problems. We've done all the tendons with it, plantar fascia. And the only big one I haven't really tried too much with is Morton's neuroma. So I'd be really interested to see or hear from anybody else who's looked on that.
Come on to that.
That's for another program.
We've got an expert in the room for that. We'll come on to that. We'll keep that as any other business. Thanks, Abid. That's brilliant.
Brilliant.
Thank you very much indeed. Brilliant.
Okay.
I'm conscious of the time, and I promised at the start that we've got some great guys here joining us this evening. So I'm going to move swiftly on to Kirsten, who I introduced very briefly earlier. So let's say hello to Kirsten. Hi, Kirsten. Good evening.
Hi. I was hearing Abid say he recognised all the faces, new faces and things, and I haven't looked because I never want to know how many people are on these things. As far as I'm concerned, there's 5 people here, and that's it.
Okay. All right.
Right. I am going to share my screen, hopefully. Can you see that?
I can, thank you.
Perfect. Okay, so I have a specific case to tell you about. Apologies if you were on the London branch meeting last week, because you're going to hear pretty much exactly the same thing as I said last week all over again. So this case was a 47-year-old male who came to see me in the clinic after having his arm bent by his wife. She was fed up with him complaining about it and made an appointment, and he came in with a 2-month history of heel pain. He was quite an active patient, or is quite an active patient. He liked to walk to work. It was a couple of miles walk to work every day. And he liked to do that walk and walks after work as well, for both his physical health and for his mental health. He had to wear safety shoes to work, and that was kind of a non-negotiable. And we all know that those are kind of the lesser of two evils, really. But his heel pain meant that he was struggling to walk at all. He had to sit in his seat once he got to work. So he had that kind of difficult cycle of activity followed by rest, which caused it to kind of stiffen up and seize up and become painful again. And it was causing him real problems when he came to see me. So I'll not go too deep into my assessment with him, but we checked him over and he had pain and palpation of plantar fascia insertion, just that typical medial tubercle of the calc, and some edema present over that as well. His pain, he was also feeling it into his arch as well, along the medial slip of the plantar fascia. He complained of first step pain, so, you know, very classic kind of plantar fasciitis symptoms. We're fairly confident. Unfortunately, I don't have an ultrasound in my clinic yet. It's on the want list, so we couldn't scan him, but just going on his symptoms and our assessment, it was fairly obvious that it was plantar fasciitis that he had. He described his pain as a 7 out of 10 at worst when we asked him about his pain score. When we asked him what, you know, if anything had given him any relief, he said that he'd done the typical Googling plantar fasciitis, and he'd discovered that rolling a ball or, you know, a chilled bottle of water was the thing to do. So he'd been doing that, and it did give him some relief. He'd also bought himself some cushioning arch supports, just the typical kind of soft gel arch supports, which he also felt helped him a wee bit. And so that was fine, but he still wasn't getting, you know, that had kind of kept him at the 7 out of 10 and gave him a bit of relief, but it wasn't improving it for him. He was still struggling. I'm flying through this, Steve. So at his first assessment, on his first treatment, we decided just to go ahead with the laser because he wanted to get better as quickly as he could. And that's what we find with the laser. It can, not always, but very often give you really quick results and reduce pain very quickly. He was one of these fabulous patients that are so satisfying to treat with the laser, who experienced immediate improvement after we treated him. So I actually can't remember exactly which settings I used for him, but I always use the scan phase first. So we did a scan phase, and then I kind of rocked the boat a little bit by favouring the Achilles tendonitis setting for the plantar fasciitis, which doesn't give a scan type treatment like the plantar fasciitis preset does. The Achilles gives you a point by point, so you treat individual points rather than doing a continuous movement with the laser. I like doing that because I like to be able to focus on specific areas of pain and around that. So I focus my treatment on that medial calc, the area around it, and then into that medial slip of the plantar fascia as well. And I also usually do trigger points too. I tend to stick a trigger point over the area of pain to hit that kind of acute element of the pain. And then I did some trigger points up his calf muscles as well, into heads to gastroc, you know, just palpating for them and treating them with the trigger point setting. As soon as he set his foot on the ground, he noticed an immediate improvement and put his pain level at that time at a 3 out of 10. I also gave him some taping. Just a standard low dye taping to do to support his foot. We gave him an exercise program to get him loading his plantar fascia, and because his current insoles were giving him some relief, and because he'd shown quite good initial improvement with the laser, rather than giving him new orthotics, I just told him to continue wearing the ones that he had, rather than spending money on a new pair that he might not necessarily need, and if he did, he wouldn't necessarily need them for long. And he was really happy with that. So I saw him a week later. When he came back, his pain was now kind of at a steady 2 out of 10. So he was doing really well. The pain on palpation and the edema were both very much reduced. He's one of these patients who wanted to be completely better. So we decided just to repeat his laser treatment again. So we just did the same treatment as the previous week, and advised him just to continue with his treatment plan as he'd been doing until his review appointment, which was 1 week later. And again, he was quite happy with that. At his review appointment, he was absolutely delighted. His pain had resolved. He'd been able to get back to walking to work again. And he lost that first step pain. He wasn't concerned about, you know, standing up after sitting down, things like that. And he's one of those patients who's kind of dropped off my radar. I haven't seen him again in the clinic, but because I live in Orkney, there are no secrets, and I see him out walking all the time now. So I know that he is okay because he's going for his evening walks, because I drive past him and I see him. So he was a very satisfying case, because in that space of 2-3 weeks, he'd gone from a 7 out of 10 to really a 1 or a 0 out of 10, and had got back to his kind of everyday activities and was very happy. So I was very happy too. Is Steve still there? Looks like he's frozen.
I think I've just had a text from him, the wonders of technology and everything. Obviously seems like we may have lost our fearless leader there. He has just said, though, if we're right to move on to Adam, we can keep the ball rolling.
Sorry.
Hopefully we're picking back up somewhere along the line. Righty. Adam, we okay to go to you? I think we're muted. Yeah.
Sorry, it's running really slow. Just trying to get my presentation up.
No problem. I'll see if we can get Steve back on somewhere.
There we go. Can everyone see that?
Yep.
Cool. Right. So, how the hell did I get to this as a presentation? I don't use PowerPoint often enough. There's a button, isn't there? Yeah. Oh, sold it. All right. So, nope. Okay. I can't get this to run as a PowerPoint. I'm totally lost and bamboozled with it, but never mind. So what we're going to do is just, oh, there we go. Is that it? There we go. That's it. So that's me. Now, basically, we've got 2 lasers in our clinic. We've got the M6 and we have the M5 with the Charlie head. The M6 is probably my favorite, to be honest. It covers a bigger range and things. So, as you probably know, it puts out sort of two different wavelengths. It's got a maximum power wattage, so we're not doing any thermal damage. And basically, you do get some training, which Kirsten does a lot of, which is excellent. So, what we have here is in clinic, basically using it on plantar fasciitis. This is one of my team. I wouldn't use it this way. If it's the handpiece, I would always move it towards the heart with the handpiece, and just kind of work on it. Sort of move it towards the heel, move it towards that area, and focus a little bit on the heel. The Charlie head's a lot easier. You just kind of set it to the power level that you want, leave it to run, and yeah, after the time limit stops, it's very good. The M6 works in a similar way, but it will actually move up and down the area, which will cover a bit more. So what I'm going to do is cover a little bit of how we treat plantar fasciitis in clinic. We've made up a set of protocols for it. So generally what we would expect with our protocols is to get a reduction in pain within 24 hours, lasting up to a week from the first appointment after laser. We put together a rehabilitation package, and usually we've got really good results within sort of 8 weeks. We kind of recommend between 4 and 8 sessions of laser to people alongside the rehabilitation plan. Usually most people will go for about 6. Occasionally we'll throw in an orthotic, but usually the rehabilitation plan involves strengthening whatever weakness is causing the issue, whether it be something such as tib post, whether it be a little bit of restriction around the ankle joint, tight calves, something that's causing it. We'll have a look at what that is. We'll do a bit of joint mobilization and usually a bit of soft tissue work as well. Now, I prefer the patient prone, sort of on their face on the plinth. The reason for that is with the M6 and the Charlie head and the handpiece, I can treat 2 areas at once. So my kind of go-to is the tendonitis setting for both. So with the M6, I would use that on the actual body of the calf and up and down the Achilles tendon and just let that run. And I would use the handpiece for tendonitis setting on the sole of the foot and around the kind of where the Hageland's bump formation is, around that area at the back, posterior aspect of the heel, going all the way forward to the metatarsal heads and kind of working that. There's a few other settings I tend to throw in there. Muscle contraction works really well, just kind of above the myotendinous junction in the Achilles tendon. So I would, again, tend to use that with the Charlie Head M6. That just relaxes the Achilles and the calf muscles around that area, just to give you a little bit of flexion and just reduce some of the pain. Again, we use muscle contraction quite a bit with the hand piece. I'll show you the areas of that in a wee minute. Inflammation, if it's true plantar fasciitis, we'll use that around the medial tubercle of the calcaneum. Brachial neuralgia I tend to throw in quite a lot. It is my favourite setting of everything. That is in the neck and shoulders for any of you with MLS laser. I don't change too much off the settings. I'm usually quite happy to use the actual settings and go with that. So I'm going to talk you through. So we're going to look at the first image, which is the one here. So I tend to find quadratus plantae and quite often the abductor hallucis and the flexor hallucis brevis can both cause a little bit of pain around that medial arch, which can mimic plantar fasciitis. Even if somebody has true plantar fasciitis, I tend to find doing a bit of muscle contraction work around this area really releases it as well and just can help with the pain. What I tend to do is muscle contraction. It's in pretty much every laser within the calf or the thigh setting within there. What I do is I set it to 1 point and I will set the time for about 4 minutes and I will just move up and down the body of these muscles. Again, tending to go from the toe back towards the heel, back towards the heart kind of area, sort of moving with the blood flow. That tends to get a really good result actually, just by sort of doing that and working these muscles, particularly since abductor hallucis can get quite weakened through plantar fasciitis. Just usually the arch is not that strong. Just having a little bit of muscle contraction just can take some of that inflammation out. Inflammation, as I've said, around the plantar, the medial tubercle. And if I'm still getting a little bit of pain, I'll focus on the medial calcaneal nerve and going down the medial plantar nerve and sort of set that to brachial neuralgia. Again, what I tend to do is that's a multi-setting and trigger points. I'll set that to 1 point, I'll set that to 4 minutes, and I'll just go up and down the area of the nerve. That tends to desensitize it quite a bit, and that's really quite useful at just relaxing everything and generally taking away that pain, which could be a bit more neuropathic and a little bit more due to involvement with the nerves. Combining that with the muscle contraction and using both of them more as a scan phase and a trigger point really seems to release things. We tend to do that if we've not had a result after about the third appointment with just more our soft tissue, with our joint mobs and some of our extras. But in general, we can get really good results within the 8 weeks by doing that, and using them as a 1 point scan setting actually makes it quite good because you can target the area you want, you can target the muscle. I always angle it slightly, so don't go directly down with the probe. I always angle it and again move towards the heart, and that way it just seems to absorb better. Because the patient's prone as well, what I'll do is tend to either dorsiflex the ankle while they're sitting there. I've got my knee against their foot and I'll be moving that every now and then, or I will be flexing the toe as well, dorsiflexing the toe as well. So yeah, that seems to be our pretty good protocol that's getting decent results. So we'll see if Gwen is ready.
Yeah, all ready. My name is Gwen Malcolm. I run the Foot Monkey Clinic up in Kirkcaldy in Scotland, just across the water from Adam, but I live in the better part of Scotland. It's Kingdom. Right, anyway, I'm not going to do any case studies or anything. It's more a case of what to expect when you're using laser, what do you look for when you're not getting the results, and what to also to check for. Adam has actually touched on a few subjects I was going to talk about, especially like some of the muscle groups. I always find that a lot of the muscle groups are confused with plantar fasciitis. If it is, sorry, I'm not very good at this. You have to excuse me. I tend to jump all over the place. I've got Asperger's syndrome, and this is my worst nightmare. Right. Anyway, so everybody's gone through what sort of settings they use, how they use it. So I'm not going to teach up people how to suck eggs. We've already gone through that multiple times. What I'm going to touch on is diagnosis. Now, if your diagnosis is not right, you can treat all you want and you're not going to get the results you're expecting. Now, some people are quite good with things like the scanner. They can have a quick look inside there with an ultrasound. That's great. A lot of us don't have that. It's on my wants list, as well as doing a few courses on it, but I don't have it yet. So I've got to work on the diagnosis. And what I've found, when patients coming in to see me have had this condition normally for over a year. So I don't get very many acute conditions. All mine tend to be long-term chronic problems. So my treatment of them is going to be slightly different to other people's. I'm a bit of a maverick, as Steve said. My past career, this is my fourth career as a podiatrist. My first career was working with radar systems, early warning systems, targeting missiles, sinking ships, and blowing up parts of Iraq back in 1991. I've been around the block numerous times, and basically I'm a veteran. So my idea of how all the system works is going to be completely different to everybody else's. So I tend to play with the settings a lot. So I'm not going to go into settings because what I use will be completely different to somebody else's. Nobody's right, nobody's wrong. It's whatever works with you. Now, like I said, a lot of the treatments I do are for long-term chronic. So you've got as well as the additional problems of trying to treat it with laser, you've got all the additional problems that come along with it. They've been limping, they've been offloading. So things like an extensor digitorum brevis is going to be sore after you've taken away the pain underneath. So this pain is going to move around in a lot of chronic conditions. So what I do, I break down the condition that I've diagnosed into its component forms. Your inflammation, your chronic pain, edema, especially, I mean, we're talking, at the beginning was talking about a turgid heel. So you've got all that inflammation, all that swelling, all that fluid, everything inside there. So I break it down and I treat every symptom, everything I find differently and separate. I too like the plantar fasciitis setting. I also work on the muscles a lot in the prone position, but I tweak it here and there, and that just comes from my background. And I'm not saying you could use all the settings, but if you use the settings in the machine, you can jump between tendonitis setting, brachial neuralgia setting, and just keep on going through it all. Now, what I've found quite a lot recently is my diagnosis has been off. I hate to say it, but I have been wrong and quite a few times. With a lot of the chronic conditions that have been coming on the past year, people have been out walking a lot more. They've started running, they've started cycling, they've started doing a lot of things. And a lot of things like retrocalcaneal bursitis, if it gets really chronic, can show itself as with a symptom of plantar fasciitis. So I have had to take a step back recently and really think about what I'm trying to do, what I'm trying to give the patient, and making sure that I give them the right treatment possible. I've got it wrong quite a few times. I've corrected myself after the second treatment, and all of a sudden they've got better. As Adam says, In fact, Kirsten said as well, when you get your first treatment done, you should be knocking down the pain a lot. And if you're not, something else is amiss there. Now, when I've done the treatment, I've worked on the back of the leg, they've gone through their exercise programs, they're following it correctly. When you've got a really turgid heel, I don't do injections, so I've got to go down to strapping. And I don't use low dye strapping at all. I use a lot of KS tape with zinc tape as well. I do what they call a heel pucker in America. It's a calcaneal fat pad strapping. And basically what you're doing in the fat pad is, if that's the toes, there's a heel pad, and up the back, you're strapping right the front of the calcaneum, round, up the back, round again, and cross over. It crosses over the back, and you do the same round the front, and the heel pad will pucker up. When you do that after the second or third treatment, their symptoms improve 1,000-fold. I've found it to be very, very handy, because all you're basically doing is pushing the fatty pad together, so you've got a big cushion. When it gets to near the last appointment, as Adam pointed across about orthotics, I never used to use orthotics for these conditions, but I've started putting them into a form orthotic because it's nice and soft, it's easy to mold, and you can modify it really quickly, and that gives them the long-term solution. But everybody else has covered what they've done with at the beginning, how they treat, etc. All I want to reiterate is make sure you get your correct diagnosis first time, because we'll all diagnose it wrong. We'll get in our heads, oh, it's plantar fasciitis. There's a setting for that, and off we go. Whereas sometimes a little bit outside the box, do a couple extra checks, and you can still treat, because sometimes, like I found with retrocalcaneal bursitis, over a long period of time, the way they've been walking, they've been pulling on the plantar fascia, and it's really tight as well, and it's causing a lot of discomfort. But it's actually only a symptom of the actual original condition. So you've got to treat the symptom, work your way back, and then treat the condition. So you're going from basically the ball of the foot, all the way up the foot, round your peroneals, round your adductors, up the back of the leg. It can be quite involving. So I hope that helps. Probably not, because my brain works a completely different way. But if it's been helpful to anybody, then thank you for listening.
Thanks, Gwen. You said this is your worst nightmare, and I have now been thrown into my worst nightmare.
I am here, if you can hear me.
Oh.
Steve is here, but in voice only. His video's not working.
I've always said.
They've asked me to direct the question and answers. So before that, I just wanted to correct something that Gwen said, and that was that he lives in a good part of Scotland, but I live in the best part of Scotland. So
oh, by the way, Kirsten, do you know Dave Flanagan?
He's a photographer.
He's a PR guy.
Yes. Orkney's a small place.
School.
Yeah, it's such a small place here. See, I told you there's no secrets in Orkney.
No, if you see him again, say hello from me.
I will do.
Doesn't everybody know everybody in Scotland anyway? Isn't that the case?
Pretty much.
We're all related.
Yeah. So I think, after hearing all about the different settings that we all use, some people might be feeling a little bit overwhelmed by, oh my goodness, how do I choose what settings to use? And when I'm doing my demos, I always say to people, until you get a feel for the machine and kind of a really good understanding of how to adjust the settings and how to pick individual elements to your treatments, there are so many presets on there that make it super, super simple to use, and just stick with that until you feel confident or that you want to choose different settings. You don't ever have to do that if you don't want to. But I think as you use the machine and get more familiar with it and the settings, then you can absolutely stick with the presets and you'll still get really good results. Would you say that's fair, guys?
Absolutely.
Okay, good. I was writing notes for myself when I knew I was going to get thrown in here. So I think what everybody said as well is that when we're treating plantar fasciitis, the laser really is part of the different layers of treatment that we throw in there. So we're looking at other things as well, like loading programs, like activity modification or footwear modification or taping or things like that. And it can be really helpful in bringing those pain levels down to encourage and enable our patients to do their rehab programs. You know, if they've got pain, they're quite often reluctant to do their exercises, or they might not do them as well or as effectively as they could. But because we've got the laser and can bring that pain down quite quickly, it allows them to do their rehab and the things that we tell them to as well. Yeah. So we have had one question from Sarah Sharp. If anybody else has any questions, pop them in the chat now, and I will put them to the guys and answer them myself if I can as well. Sarah Sharp has asked around frequency of treatment. I think Adam maybe said he does, was it twice a week, Adam?
Twice a week, and we try and do sort of twice a week if we can. Depends what day they come in on their first day, but what we do is the first week we try and do twice in the first week, then once a week, and then once a week for 2 weeks, and then 2 weeks after that. Just because that way we can kind of extend the program, add orthotics and stuff if we need to, but we can assess it over, by that point you're talking about a 6 week gap.
Yeah. Okay. And Gwen, how often are you seeing patients? Sorry, how often would you be seeing someone for plantar fasciitis treatments?
I do first treatment first week, second treatment late. It's got to be less than 7 days later. So I tend to move into the second week. And then the third week, that's when I start introducing the taping. Fourth week, start thinking about the insoles. I then give it a 2 week gap. Same as I think we're probably all about the same, this 2 week gap to see how it all resolves. Because a lot of the settings you're using, I mean, the pain setting works right away, but I think if you're doing a biostim setting, it carries on working long after you've put that laser away for the night. So you need to see how that's going. So I gave it a 2 week gap and then back for a week, and then we check it from then. And if they need a top up, they're welcome to come in. But so far, touch wood, I've already had one person come back for a top up after doing 6 and 8 treatments.
Yeah.
So,
yeah.
And he was a numpty, he went out running.
You can't save some people from themselves.
Yeah, 25 miles he did.
My goodness.
Exactly. They came in completely, his heel was sore.
Yeah.
I re-educated him all about easing himself back in again, because that's how it started in the first place. He just forgot conveniently and went running again. So
yeah.
But I think he's back up to, I think he's doing 10Ks twice a week.
Excellent, excellent. I think, you know, ASA recommend, their kind of recommended treatment protocol is 3 treatments the first week, 2 treatments the second week, and 1 treatment for the last week. But I don't know that there's many of us pods that actually stick to that. I think that's the beauty of the laser as well. Is that, you know, my patients want to get better, but I just don't know that they're dedicated enough to, you know, they don't know if they want to get better that much, that quickly, that they can spare, you know, 3 trips to the clinic in a week. So I think we all kind of managed to make that work for our clinics as well, which is the beauty of the laser, I think, as well, is that you can kind of veer away from that a little bit but still get really good results. So in our clinic we just do weekly intervals because that really, we're so busy at the moment, that's all we've got capacity for, and our patients are happy with that, and we still get really good results. I mean, we're usually looking at about 4 treatments at the most. Some need 1 or 2 more, some need a couple less. It just, again, as I'm always saying, it very much depends on the person in front of me. And I don't know about you guys, but I tend to find that there isn't necessarily a connection between how chronic or how acute their plantar fasciitis is as to how quickly they respond to the laser and the treatment. You can get chronic people who respond really quickly and acute people who maybe need a few more. Do you find the same?
Yeah. Everybody, the way I see it, we're all different.
Yes.
Some people you give 1 treatment to and they rebound right away, and you've hardly put any energy into them. Another person, you can fry them and have no rebound. I mean, everybody's different here. I try and keep it to affordability, personally, for returning back. I don't know if my patients could actually do the 3 a week and things like that. So I agree with what you say. Yeah.
Yeah. But that's
just,
it. I think
just jumping in, Kirsten. So I don't know if you can hear me. It's Steve. I guess, thankfully for everybody, you can't see me. I've always said I've got a great voice for radio. Well, no, I've got the face for radio. I just haven't got the voice for radio. But anyway, on the frequency thing, not to dwell on it too much. I'm sure that I believe there's one or two other questions there. You know, ASA gives some guidelines, and at Celtic SMR, you know, people when they're looking at the laser, they want that kind of guidance, that kind of assistance, and we say the 3-2-1. I like it because I'm a Dusty Bin fan for our older viewers out there. But what you guys have proven, I think, Adam, Gwyn, and Kirsten, yourselves, is you don't have to stick to those. You can move it around, and it's still very, very effective. And the other take-home messages, and Gwyn touched on it, it's with the laser, you get this accumulative effect.
Yeah.
Paul City, who does a lot of our training, I know Gwyn and Adam and Kirsten, you'd have had training from Paul, and he talks about, you know, if you imagine the child on the swing, and if you give it a good push to start with, that swing will go back and forth 6 or 7 times. If you don't push the swing again, it'll eventually come to a stop. But if after 6, 7 swings, you give it another push, you're getting that accumulative effect. So it's getting the right balance between, I think Gwyn said, after 7 days, you probably lost the effect.
Yeah.
You know, we've had a sports injury guy come on and talk to us from Bulgaria. He treats professional sports people. He has the luxury of seeing those professional sports people every day. You know, if a tennis player is injured, what else is he going to do? He's going to come to clinic and get treated for another 10 minutes. So yeah, they have the luxury of that. In practice, you guys don't. I think a comment's come on here. It's very difficult. I'll go back to it in a second. It's very difficult, you know, to get your patients back 3 times a week potentially. So yeah, there's that kind of broad window of when you treat and how often you treat. The more you can see them, and again, I think it was Gwyn, talked about affordability, or was it Adam? Beg your pardon. It was Gwyn. But yeah. It's weighing up your patients' affordability, weighing up the availability, your availability of clinics. I know a lot of you at the moment, you're doing 12-hour days non-stop. So it's weighing that up to get the best result for your patients and getting their commitments. Anyway, I've dwelled on that. So Kirsten, back to you. That's
okay. I'm just watching some questions coming in and comments. Kate Hathaway saying that she struggles with that time frame being rural, and for us rural people, that's definitely a thing where we've got to consider our patients have to travel to get to us, you know, so being a bit flexible with that protocol is helpful there too. Catherine Fletcher Little, hi Catherine, is asking about price structures. So I'll just kind of cover mine quickly, and if you guys are any different, just jump in. But we do an individual price if someone just wants to try 1 or 2, but we also do a course price. For us, it's a course of 4. I know other people kind of do a course of 6, and then we reduce that price slightly if they need a couple more after that. Then does that kind of fit in with where you guys are too?
I stopped the multiples,
yeah.
So I only do individual treatments.
Yeah, I'm considering doing that as well.
Unfortunately, with Kirkcaldy, Adam would be the same with the area he's in. It's quite a depressed area. There's not a lot of money, and forking out a large sum of money, we're finding we're scaring people away. Okay. Now, I only charge introductory offer that's gone on for about nearly a year now, 45 quid.
Yeah.
So a rule of thumb, Kirsten, a rule of thumb to answer the question, because everybody's in different areas around the country.
Yeah.
Is I always say, look, what you typically charge now for your routine treatments, charge that plus 50%. I say the 50%, I recommend the 50% because I'm a big believer in reinvestment in the equipment that you purchase. So that also then keeps you within your price range of your customer willingness to pay, if that makes sense. You know your customers best. So if you charge £30, it becomes £45 for the laser, and you can always then do package prices. So 4 lots of 6 45s. I can't work that out. What's that? 240? Don't know. My brain's frazzled. And so the 240, you say, well, we'll do it for 225. You do a package price, but you don't have to do that. So work on a basis of typical charging 50% upwards. If you're like me, you believe in reinvesting in the equipment.
So what we've done is we charge 50, but if they do a package, what happens is it'll go down to 45 per appointment, so it saves them 30 quid if they get a session of 6. But rather than ask them to pay all that up front, what we've been doing is get them to pay sort of per session. So let's say Kirsten came in tomorrow and was signing up for 6. What we would do is book your 6 sessions. So you would pay for session 1 and 2 in your first appointment. You'd pay for session 3 at your second appointment all the way up until your last session, session 6, which you've paid for at session 5, so you pay nothing on the last appointment.
That's clever.
We also find that works quite well because a few
Yeah.
patients are then like, oh, that's amazing, I feel better, and that cost me nothing. And you're like, well, you paid before, but it's a little trick of the mind as well.
We've done similar. We charge 55 for individual treatments, and we do the course of 4, which is 200. So they're saving £5 on a session in a course of 4. But we'll charge them 55 for the first 3 and then 35 for the 4th one. So that brings it down to the same price as a course. So they're, they're finishing the course, but they're not being penalised for not committing to it straight off the cuff. It works well. I am just going to fly through the other questions because there's more coming in, if that's okay with you guys. I'm going to have to go up a wee bit here. So how often do you use the CPW setting? For me, I really don't use it very often. I tend to use it if I've got a patient who I have used the laser on and I've not had the results that I was hoping for, and it's probably like a bigger area, like a knee, like an arthritic knee or something that I need to pack a bit more of a punch into, then I'll go into CPW mode to kind of just give them a harder hit, if you like, with the laser, and that tends to work quite well. Are you, Adam, using it fairly often or not really?
Not that often. I'm finding it with the neural side of it, for something like, perfect example, the retrocalcaneal bursa, which is very difficult to get into to try and knock it down. Fry it with that, it does. They feel a difference then. But you've got to make sure you've got a couple of appointments under your belt.
Yes, you don't want to rebound them.
Yeah, you don't want to rebound them the first time.
Yeah, good point. I never use CPW at a first treatment because I want to know how they're going to react to the laser. And if they're totally fine, then, I would absolutely consider using CPW after that. But if there's someone who's, they felt a wee increase in their pain afterwards, which to be fair is the minority, it doesn't happen that often. But I always stick with the presets. I very rarely change anything at their first appointment because I just want to test the water and see how they're going to respond to that at that point. Okay, so CPW, not that often. Steve mentioned treating Morton's neuroma with laser. Gwen, I know this is your thing. And there is a recording already, isn't there? You did
there is a recording already.
Yeah. Do you want to just give a quick recap, maybe?
Quick rundown of Morton's neuroma. It does work, and it does give fairly good coverage and knock down the pain. Not 100%, but a good 90%. The big problem with it is actually getting the wand into the right angle to actually hit where it is and using the correct settings. Break the condition down, so you've got your inflammation, you want to increase the blood flow into there, and you want to knock down pain. So basically, basically what I use is 2000 hertz, 1250 hertz. I use 250 hertz for the pain, and I also do a couple of hits, 3 hits. 10 hertz, 23 seconds, 100%, zap it in there. And if it doesn't quite get rid of it, give them another shot at 10 hertz. Break it down nice and simple. It does work, but they might not get the results they want. They want instant results like the plantar fascia. It takes time. You're looking at 6 to 10 appointments.
Okay.
Funny enough, all the ones I've done were all on the right foot, and they're all golfers and they're all male. So that tells you about the sport.
Yeah, interesting. Thanks, Gwen.
Yes.
And maybe Steve could maybe share the recording that they've got already on one of their pages or something, Steve. Would that?
Yeah, I can do that. If
there?
anybody would like that, I just drop it on chat, and I'll keep a note who would like to see that. Thank you.
And Mary's asking, what other conditions, or Marie, sorry, what other conditions are you regularly using laser for? Achilles tendonitis or tendinosis, I think, is probably our most common situation, which probably answers her other questions. Any luck with Achilles or osteoarthritis? And I would say those are the 2 things that we probably use it for, alongside plantar fasciitis the most frequently. And we have really good results with both.
Morton's neuroma, capsulitis, retrocalcaneal bursitis, Achilles tendon tears, gosh.
Wound healing. Use it post nail surgery as well. In our
Yes,
post
yeah.
nail surgery package. Good for, and I know Adam does too. It's
Yeah.
good for kind of speeding up healing and reducing infection risk in wounds.
Especially as the age increases as well, it brings them back and heals them quicker. Yeah. Oh, forgot about that one.
Yeah, so I think it's basically, Baxter's neuritis would be another one. Anything where there is pain and inflammation involved, you can put the laser on it, basically, or where you need to create a healing process, and that would include acute injuries like lateral ankle sprains. You could be using the laser on that as well to kind of calm down that pain and to get it to start healing more quickly. Michael, I've had success with meniscal knee pain. Has anyone used it on a Baker's cyst? I haven't.
One.
Oh, you have?
Yeah. I mean, that's the cyst at the back of the knee. I mean, it wasn't great. It wasn't great. I'm the world's worst. If somebody says I've got a problem, I'll give it a try with laser. There's no point in having the machine and saying, oh, I've not got a setting for that. I tried it with one. It reduced a lot of the pain down, the discomfort down, but they actually had osteoarthritis at the front of the knee and round by the patella. So I was treating that anyway, and I just gave a whap underneath. I can't even remember what setting I used, but it didn't reduce much. But the osteoarthritis part over time, as we well know, with the Charlie heads, strap that on the knee, it gives a good result. It gives a good result. So I can't say yes or no if it was good or not, but I have tried it. Never saw the patient again, unfortunately.
Yeah. And I guess it is the type of thing where not everything works for everyone, and it doesn't work 100% of the time either. It works a lot of the time, but not necessarily for everything. And I know Steve's always saying, they are completely clear with that. There are certain conditions that it might not hit, it might not work for. Thanks, Gwen. You're helping me out here a lot. Can you overdo the use of the laser? Yes and no. There's a maximum number of joules that you can put into a person in a day. They kind of suggest 3,000 is the max number of joules per day, but you'd need to laser a lot to put in 3,000 joules in a person. I would say my average per session is about 300 to 400. I guess because I'm not as hard as Gwen, I'm a very cautious laser user, but the rebound effect is the thing where you're putting too much energy into a person too soon. You've maybe not done that initial treatment and got a feel for how they're going to respond to it. In that case, technically you could class it as overusing the laser, but you can't necessarily cause harm. You're not going to overheat the tissues or cause any thermal damage by using the laser too much. Jonathan's sharing his prices. They've put their prices up and had more people take it up, which I think is relevant because people do value things that they pay for sure. And I know that Jonathan always charges a good amount, which is great. So there's definitely something to be aware of in that it is worth charging more for your laser because your patients value it more. Plus you're going to get that return for your investment as well.
What Jonathan does is work smarter and not harder.
He works smarter, not harder.
Thanks, Jonathan.
Jillian's asking, where do you get training during COVID? It's all done online at the moment. Is that right, Steve? It's all done through Zoom calls? Yeah,
it's all working quite well on virtual demonstrations at the moment. So what we do is we get the laser to you, so you have it there physically to use. So then we line up a demonstration over Zoom. And we're finding a 2-3 hour session is getting you up and running, and we encourage you then to use it. So you certainly get enough training in that Zoom session, and then we encourage you to. Then we have typically would recommend a follow-up call with the demonstrator, follow-up training session, a week or two, depending on how much you've used the laser, because that will generate some questions yourself in use. So, what was the question? Sorry, how do we do it? How do we deliver it? Is it just about how we delivered?
Yeah, just where do you get the training during COVID?
Yeah,
so
we're doing it virtually. We're looking forward to all our users, and we're looking forward to doing the workshops again very, very soon, of course, when we're allowed to. So we've missed doing them this last year, but so of course Zoom has stepped into the breach. Who knew Fat Larry was so smart all those years ago? Zoom has been the way forward. So it's working well. It's working well, I have to say. The virtual demonstrators seem to be working because you've still got a practical element to it. You'll have the laser in your hand.
Yeah, it takes about 2 hours on average, I would say. Just asking how long it takes as well, so about 2 hours roughly. I think that's about it. A few comments, and Steve, you might know the answer to this one. How many podiatrists have the laser in the UK?
That is a good question, and I should know that. It's in excess of 60 now, I would say. 60, I would say, podiatrists, which I'm very proud of. 3 years ago, you know, I think we had 2. I know we had 2. Well, I suppose at one point we only had 1, and we had none at one point. But anyway, two years ago we had very few, and in the last year or so, we've got definitely over about 60 or so now, right across the UK. Sorry, was that podiatrists, specific to podiatrists? That would be 60 across the UK for all users. So that would be
okay. Yeah, specific for podiatrists.
Sports injury clinics, but a good 2/3 of that would be podiatry.
Yeah.
We've had a really good take up in podiatry. It's just an area that I know historically from my background of working for Canonbury. When I joined Celtic SMR Healthcare just over 3 years ago, you know, we've been Celtic SMR is a very, very successful company in the veterinary market. We've been selling the lasers to vets for 7-8 years now. 3 years ago, ASA said to us, 3.5 years ago, ASA said to Celtic, why are you not selling to healthcare? This is brilliant. It's all around Europe. They do it in Europe, in Asia. You know, we didn't know we could. We will. So we started approaching. We were new. That's when Celtic SMR Healthcare was born. Because of my background with podiatry, you know, thankfully some podiatrists took my call. One of them on here tonight, Jonathan. That's where the momentum started in podiatry, really. So I had no other reason than that. Yeah, 60 in the UK, which I say is, you know, given the last year, we're pretty proud of. And I have to say, final word on that. Sorry, I know you can't see me, but you can't stop me talking. I have to say, 70, 80, probably even maybe 90%, 9 out of 10 sales have come from recommendations of existing users. They love it to the extent that they just can't wait to tell their friends. And, you know, so once we sold one, it was just a case of word of mouth thereafter. Very proud of the support that we deliver to people once you've got your laser, well, to get the laser, and once you've got the laser, not least the webinars and so forth. And that's a big part of what we do. It's you know, and I don't know if anybody out there would agree with that, but the support we offer to our people, our users, our ASA laser superstars, as I prefer to call them, that's everything to me. It means the world. Yeah, the success has been, I believe it's success. The success is very much on the back of recommendations from other users.
The support after purchase, I think, is the best that I've ever had from any other company. It's been excellent, and the CPD and everything too. I mean, that's why I'm here. That's why I'm doing this now. It's kind of on the back of that, and as a result of that, so I can say from personal experience for sure. Steve, I don't know if you can see these questions, but there's just one more about the cost of the laser, the general cost. That's your zone.
General cost, okay. So the MV unit, the main unit that most users will have, and we recommend from the start, is that comes with the handpiece. That starts at 7,950 plus VAT, so just short of £8,000 plus VAT. Can be financed. You can finance that over 5 years. Off the top of my head, a very rough figure, that would cost you £200 a month, under £200 a month, which when you weigh...
4 treatments a month at my prices.
Is what, sorry?
4 treatments at my prices,
which
one
is,
at Jonathan's.
Yeah, which, exactly, we go back to the question about what you charge. That's £1 a month to cover your investments. You may have heard Gwyn and Adam in particular refer to the Ultra head or the Charlie head. You can upgrade, and that's this additional diode. So this is that's a further that to have that whole set is a full is £12,000, 11,950 plus VAT. But what we're finding with a number of podiatrists in particular, what they're doing is they buy the MFI unit initially, the £8,000 price that I mentioned, and then you can upgrade to the Ultra Head later on if you wish to. And there's no downside to that. The units come with 2 channels, so you can plug the Ultra Head in afterwards. You don't have to make a choice of, or do I spend £8,000 now or £12,000? There's no catch, or well, you should have bought the different unit if you want to add the Ultra Head. So that's the really good thing there, and we've had a really good uptake on that. Probably got a quarter of our users out there now with the Ultra Head. Love the laser so much. That's what they want to invest in next. So 2 price points basically. Well, no, there's 3 price points. Adam's going to be wondering why I've not mentioned the robotic. There's 3 price points. So you've got the portable unit, £8,000 just short of for VAT for quickness. With the Ultra Head, the MFI5 as we call it, that is 11,950, 12,000 plus VAT. And then there is a robotic version of that too, which is £16,000 plus VAT. So there are 3 price points to mention, but you can have one of these for 7,950 plus VAT or finance for £200 per month.
I think that's it, Steve. Kate Hathaway's looking to see if anybody here's a sports and remedial massage therapist. I know that she'd love to contact any other laser users who are sports therapists or massage therapists. So maybe that could be organised through you guys, Daniel.
Yeah, we'll follow up on that. Who was that from?
From Kate Hathaway.
Okay, we can follow up on that, of course. Yeah, absolutely. There are is the answer. There are other sports therapists out there. I just don't know off the top of my head. And we do have a laser forum on Facebook for those of you who are not already a member of that. That's members of that. If you are a user, it's a very exclusive group. So if you are a user of ours and you're not already on the forum, then let me know. We've obviously missed you, or if you've got any colleagues that we're not aware of, make sure they're on the forum too. It's a really, really good support network. It is, with regards to the forum, I'm being a bit exclusive because those of you out there that don't have a laser yet, you won't be able to join. I always, because we are keeping it exclusive to our users, or at least people that are trialing the units. I always say it costs £7,950 to join our laser forum, but you do get a free laser. That's my little joke.
I think that's it. That's all questions.
Is it? Great.
Yeah.
Sorry, I dropped out at some point. In many ways, I'm sure that you won't want me to apologise. That probably improved the situation for most. And I haven't been as responsive as I'd normally like to be on these webinars, on the chat and so on and so forth. So if I've missed any comments or any requests there, we do save the chat, so it won't be missed. I'll pick it up in the morning. Kirsten, thank you ever so much for stepping into the breach. Really, really grateful for that. Put you on the spot there. And I know how much you love these things. Thank you again for your presentation. As of course, I will say thank you to Gwyn, the Maverick mouth. Thank you very much for your input. It was really, really insightful for the guys out there. General takeaway message of, get it, use it, and seek and improve your patient's situation. Adam, always grateful to you. Thank you so much. You've been a great support to me and Celtic SMR Healthcare again. So thank you for your presentation and your input there too. Really, really grateful to everybody. Sorry, I can't, if I'm not responding to any chat. If there's I hope you're. Oh, actually, I'm just getting my chat back now. Oh God, you don't want me to start at the beginning, do you? Anyway, let's leave it there. Unless there's anything pressing there that anybody wants us to still answer. I've now got chat back. That's good. So I will catch up on that shortly, guys. Thank you everybody for joining us. Thank you coming up from Jessica. Thank you, Jessica. Jessica's an laser superstar joining us. Gillian, could you send it to? Yeah, I will send that to you, Gillian. Yeah, no problem. Thank you everybody. Big thanks again to those that contributed, and needless to say, to finish, If you'd like more information, just drop us a line. We will obviously follow up on that. We're more than happy to arrange free trials of the equipment with the demonstration that I touched on. Give it a go. Find it out for yourself. You know, and you know, let us help. Let us help if we can. So many.
Whether and definitely try it. That's what sold me. I was in two minds. I tried it for a few weeks, fell in love, and I think I was on the phone to you after like 3 weeks, Steve. So yeah, anyone thinking about it, try it.
Nothing to lose from a free trial.
No. Thank you, Adam. Absolutely. Brilliant. Okay, thanks, Kirsten, for taking over.
That's okay.
Apologies again for any mess ups that I've added to, but thank you. Big thank you to everybody. Thank you for everybody for joining us. Stay safe, stay well, and we hopefully will see you soon.